So overall, this presentation, I've broken it down into three areas: terminology, overview, followed by some supports at the end. And let's start with a quote from the Bible around a psalm that we're very familiar with, and that is Psalm 22, "The Lord is my shepherd, I shall not want." And something I want us to consider throughout this presentation is, how can we support one another, but at the same time support ourselves? And one thing as Orthodox Christians, is to consider our faith in God's care and protection of us, especially in hardship. So I'm going to start off with terminology, because I think it's important we identify terms to decrease any ambiguity, let's say. So in Australia, 75% of Australian adults have experienced a traumatic event. So what does this actually mean when we're talking about vicarious trauma? 75% of Australian adults have experienced a traumatic event, yet most people who've had an experience of a traumatic event don't go on to develop a mental illness. And so it's important that we recognize the exposure to traumatic events is high, but the development of mental illness is quite low. When we are talking about statistics, 1 in 5 adults and 1 in 7 young persons in the last 12 months, according to the Australian Institute of Health and Welfare, have experienced a mental disorder. And when we're looking at the financial cost in dollar terms, 13.2 billion, which is around 7% of the total government expenditure, was spent on mental health services in 2022 and 2023. The reason why I haven't got up to date, or that is the most current data, is because it takes several years for data to be analysed and then presented. I'm going to look at the etymology of the word trauma, because it is a Greek word. And more importantly, it means an abnormal condition of the body produced by external violence. So something that happens outside of us. And within health, we used to talk about trauma as being the event, like the car crash was the trauma. But what we're now starting to talk about is trauma is actually the wound, what happens to the person. So the emotional response to the distressing event. Now, I've got a term here from the Australian Psychological Association, and they refer to trauma as very frightening or distressing events may result in psychological harm. So not physical, psychological harm. And this harm is called trauma and can affect a person's ability to cope or function normally. I want to emphasize now, and I've got it in very small writing down the bottom to remind myself, that not every hurt, not every hardship, not every event is a trauma. Vicarious. So when we talk about vicarious, there's no medical definition. So I actually had to go to the dictionary. And the dictionary refers to it as experienced as a result of watching, listening, or reading about the activities of other people. So it's a subjective experience. And it's, again, something external to us, something we saw, something we heard, something we were told about, which we ourselves didn't go through. So we have to consider, if many people hear about a similar event, read about a similar event, why is it that they don't all experience vicarious trauma or trauma? How is it that our interpretation of the event has contributed to how we perceive it. And we have to consider our own experiences in life, our own beliefs, our own ethics, our views, and realizing that we may be individuals, but our own way of being contributes to how we view the world and then how we interpret the world. So if we're looking at vicarious trauma, and you're saying, well, Vasiliki, how do we diagnose it? Interestingly, the textbook or the criteria for diagnosis is called the Diagnostic and Statistical Manual of Mental Disorders. And interestingly, vicarious trauma is not considered a formal diagnosis. Within health, vicarious trauma is considered a cluster of symptoms that make up the vicarious trauma, and I'll go through those shortly. What I did find in relation to a definition was I went to our colleagues in the Law Society. And interestingly, the Law Society actually have a definition for vicarious trauma. And their definition is vicarious trauma refers to the emotional and psychological stress experienced by individuals who are exposed to the traumatic experience of others, often through their work or relationships. So again, it's emphasizing something that's happened external to us that we've either heard about, and that has had an emotional and psychological stress for us. When we're looking at vicarious trauma, the literature tends to say that it's a sinister onset through repeated encounters over the course of one's career, and that because it's done over a period of time, it can actually increase our symptoms with repeated exposure. And so when we're trying to, again, identify, well, what's the correct words that we use? What's ended up happening is that we have terms or concepts that have been used interchangeably with vicarious trauma. But these terms that I'm about to talk to you are actually separate to vicarious trauma. And what I mean by that is they're not vicarious trauma, but they may make up, because remember when we went back, I talked about a cluster of symptoms. And so when we're talking about cluster and relational concepts, you may, in some conversations, someone may say, oh, look, I'm burnt out. I have vicarious trauma, or I'm experiencing vicarious trauma. That may not always be true. So what I'm trying to do here is say, look, there's a bunch of terms that are used in health and in the literature that unfortunately sometimes are used incorrectly, interchangeably. And I just want to go through and talk about what each of them are and how they're interpreted. And when we're looking at burnout, before I get to burnout, sorry, I just want to show you, this is the American Psychiatric Association Diagnostic and Statistical Manual of Mental Disorders. It's called DSM-5 because it's the initials, and it's called 5 because it's actually the 5th edition. And this is the text that in Australia and in North America, this is the text that's used when wanting to diagnose. So I'm just looking, so just to clarify, vicarious trauma is an indirect experience. And we need to recognize that it is our perception of what we've heard that may lead to the following things that occur to us. So I've put burnout here, and yes, I have a car of a burnout, but there is meaning to my madness as to why I used a car for burnout. So when we talk about burnout, burnout is related to your job. So it can't be related to your relationships in your personal life. So you can't sit there and say, oh, my boyfriend or my husband or my wife is driving me crazy. They've given me burnout. I'm so exhausted. Burnout is related to your role, your work environment, and it occurs from the lack of support that you feel you don't receive, either from your managers or the organization, or because of a lack of resources. And when we're looking at um, burnout, there's this constant reference to exhaustion. So emotional, mental, and physical exhaustion. And the way we view burnout is through high sick leave in our colleagues or ourselves, being late for work, being slow in our production, not meeting our KPIs. What's interesting, though, about a burnout in cars, and it's just something for you to think about. What a burnout is you actually have the tires spinning while the vehicle is stationary in order to create heat and smoke. And that elevated temperature for the car tire is what actually creates traction to stabilize the vehicle staying on the track. So, although in health we view burnout as something negative, a vehicle actually needs the heat that's generated to cause the friction to create traction. And it's just something I want us to think about, that under pressure, a vehicle, which is an inanimate object, actually does well when there is friction. So I'm going to talk about friction a little bit later, but it's just something I wanted to plant a seed in your mind when it comes to burnout, because many of us will become extremely productive when we're at work and we realize, oh my God, I've got a deadline, and for some reason we become slightly manic, and we put all our effort into meeting the deadline, and the deadline gets met. But over a period of time, that's not always sustainable. And so hence this emotional, mental, and physical exhaustion. But it comes when you don't feel supported by your peers, the organization, or you're lacking resources. So there's this loss of autonomy in your role because, again, you don't believe that you are doing your role well, that you have the resources to complete what's required. So in health, we have something called the International Classification of Diseases. We're up to the 11th edition, and this is just a code that's used to classify diseases. So when you come to hospital and you say, oh, I'm having myocardial infarction, a heart attack, the triage nurse will, log it into the computer, and that diagnosis is allocated a code. It's allocated a code for many reasons. One of it is for categorizing diseases. Another one is for funding. But what's interesting is that burnout, even though it's not classified in the DSM-5, it is actually classified in the ICD-11. But it's not classified as a disease or an illness. It's classified as an occupational phenomena. So again, linking burnout solely to the work environment. So again, because it's linked to an occupational phenomena, you can't actually use the word burnout in relation to events about your personal life. So just to summarize, a burnout, not classified in the DSM-5, which is the Diagnostic Criteria Manual. It is, however, classified in the ICD-11 as an occupational phenomena. And what's interesting is that the literature says you need 3 elements in order for a burnout to be called a burnout or classified as an occupational phenomena. And again, it's around the element of exhaustion, this fatigue, feelings of energy depletion or exhaustion increased mental distance from one's job, reduced professional efficacy. So again, bringing it back to this concept of I'm unable to fulfill the requirement of my role that I perceive I should be doing more. I believe I should be doing better. But because of the lack of resources or the lack of support from my manager or my colleagues, I'm unable to fulfill what I perceive I should be doing. Now, compassion fatigue. What's interesting is that what I find interesting as a nurse is that compassion fatigue initially came out of the research done on nurses in intensive care. And what they initially saw, and this is why they called it the cost of caring, because nursing is considered a caring profession, that they found in the literature, they found through these studies that there was nurses in intensive care, and some would actually become preoccupied with internalizing the trauma and the stress which their patients were experiencing. So when we're talking about compassion fatigue, it's looking at the individual person internalizing what they perceive the other person is feeling and suffering. And it's not an empathy, it's a sympathy. And again, this sympathy that you have for the individual to the point of exhaustion. It's when they looked at the patients, they weren't all trauma or victims of violence or victims of war. They were predominantly people with chronic conditions who some were actually at end of life. And what they identified in the literature is that these clinicians had this deep desire to alleviate the pain and suffering of the person they were looking after. And with compassion fatigue, just like burnout, it is not classified in the DSM-5, so it is not a diagnosis. But unlike burnout, it also does not appear in the ICD-11. What this means is that if you turn up to emergency and you're saying, I feel really anxious, I'm stressed, I don't know what's wrong with me, I'm feeling overwhelmed, I'm looking after all these patients, the clinicians can't actually diagnose you as having compassion fatigue because in the diagnostic criteria manuals, it doesn't exist as a category. So something for us to consider, again, as Orthodox Christians, is this quote from the Bible, from Isaiah. But those who wait on God shall renew their strength. They shall mount up with wings like eagles. They shall run and not be weary. They shall walk and not hunger. And what this Bible passage is talking about or reminding us is that God gives strength to the weary and brings comfort. Unlike burnout and compassion fatigue, post-traumatic stress disorder is classified in the DSM-5. It is an actual diagnosis. However, to diagnose post-traumatic stress, there are multiple diagnostic criteria that the individual needs to meet. It is exhaustive. And I've just put in part of the diagnostic criteria, but what PTSD says in the DSM-5 is that it's an exposure to an actual or threatened death, serious injury, or sexual violence, and in one or more of the following ways. And in the literature, post-traumatic stress disorder, I guess it had its it's not that it started to be written about, but the term was coined following soldiers' return from the Vietnam War. So in the 1960s, so just over 50, 60 years ago. I've put in secondary traumatic stress. Again, not something that's found in the DSM-5 or the ICD-11 code, but it is referred to as an occupational stress syndrome. There are two I guess, ways of this term being documented in the literature. The first is, and I've quoted it from a researcher by the name of Figley, where they say describing physiological and psychological responses following secondary exposure to challenging events or materials. So when we're looking at that definition, it's actually about the individual again in relation to their work occupation. However, there is another view that secondary trauma may occur in some patients or some persons who go to court and have to retell their story. So let's say you're a victim of a traumatic event and you go to court and you've got to retell your story, your event, your perception of what occurred. That can be quite distressing, and that has been referred to as secondary trauma. But also, let's say a patient comes into emergency. It's a woman that's been violently beaten repeatedly by her husband, and the woman tells her story first to the triage nurse, then repeats it to the intern, then repeats it to the consultant, then has to repeat it again to the forensic nurse, then has to repeat it again to the police. Each time they're retelling that distressing event, that can become quite traumatic for that individual. So something for us to be mindful of as clinicians when we actually have someone in our care, and we sometimes need to think about, okay, I've got someone here who's just had something traumatic, a traumatic event that has occurred. How can we minimize further harm to this individual? And so I just want to go through, well, if vicarious trauma isn't something that's diagnosed because there's no criteria for it in the DSM-5, it doesn't fit in the ICD-10 code, so I can't classify them as a triage nurse. Well, Vasiliki, what is it? So I've broken it down with feelings and physical symptoms from the literature. And I've put here melancholia, which is, of course, a Greek word, but it actually is sadness with no obvious cause. I put down low mood, sadness, anxious, anger, grief, but I haven't put down depression or anxiety. And I've just been a little bit tricky with that because I want us to realize that we all have feelings of melancholia at times. We all experience feelings of low mood, sadness, anxiousness, anger, grief. This does not mean that we have a mental illness or a mental disorder. And it doesn't mean that what am I trying to say? And it doesn't mean that it is something that is diagnosable. And so for persons who have major depressive disorder, that is something that is diagnosable, and it's something that can be traumatic for that individual. But so too is generalized anxiety disorder. So again, bringing it back to the language we use and the words we use, and the fact that you can be depressed without having depression. And I know I'm picking here at words, but the reason why that's important is that we don't identify with our illness or our feelings. You know, like I may feel anxious, but we find that when we start to identify with our illness, it becomes problematic. And I say this as someone who's a nurse, who in healthcare we talk about, and I think Vasily spoke about this, or Vlasi, sorry, Vlasi spoke about, holistic patient care, person-centered care, and yet we use terms like diabetic patient, cardiac patient. We're actually labeling patients by their illness, their disease, instead of saying the person with diabetes, because I'm sure that they're more than a diabetic patient. So again, just something for us to be mindful of. And physical symptoms, think about what occurs. You have an elevation in cortisol. Cortisol raises your blood pressure. It can also raise your heart rate. It may cause vasoconstriction, causing headaches. The vasoconstriction shifts blood to the heart, lung, and brain, which means we get GI problems as well, irritable bowel, nausea, may have, I didn't put it down there, but changes in your bowel motions, nausea, vomiting, fatigue, insomnia is a big one. And what we find here with physical symptoms, and this was said to me by a neurobiologist, your brain does not know the difference between physical pain and emotional pain. So sometimes when your patient, and there's this, and I'll finish the sentence off, and the neurobiologist said to me, Vasiliki, if you get a patient that comes in and they're feeling sad, instead of offering them antidepressants, just give them Panadol. And I thought, oh, you're mad. But as a nurse, anecdotally, I've seen this work. I'm not saying that we need to go and do randomized controlled trials with, placebos and what have you. But what's interesting is that the power of the brain. And I also want to emphasize that there is a Japanese, there was a syndrome diagnosed in Japan called Takotsubo syndrome. And Takotsubo syndrome was patients who were presenting to emergency, and some of you may have heard of it as broken heart syndrome, where they were actually presenting to emergency with the same symptoms of someone having a heart attack. But when they did their tests, they actually were not experiencing myocardial infarctions, heart attacks. But there is actually a term for this, and it's called Takotsubo. So again, how powerful the mind is in how powerful is our mind in manifesting physical symptoms just by what we're thinking. So when we're looking at behaviors, this is behavior where they're trying to increase the dopamine to numb pain. And so they may withdraw from social gatherings. There may be avoidance of family and friends, risk-taking behavior, the use of alcohol and other drugs, irritability, hypervigilance. Forgot to put tobacco smoke there, but that's another one as well. And when we're looking at supports, I want us to be mindful of this quote from Galatians. Bear one another's burdens and so fulfill the law of Christ. For if anyone thinks himself to be something when he is nothing, he deceives himself. But let each one examine his own work, and then he will have rejoicing in himself alone and not in another. For each one shall bear his own load. And what this quote from the Bible is talking about is mutual support and shared burdens. So initiate caregiving, help each other, but also do not be a needless burden to others. When I looked at the supportive approaches, I broke it down as a primary healthcare researcher, where we look at, we think of supports as a river, and we talk of upstream approaches as being proactive and downstream approaches as being reactive. So upstream, the problem hasn't occurred yet. We're trying to prevent it from happening. And downstream approach is the problem has already occurred. So what can we do to support the individual from having further exacerbations? And so when we're looking at upstream approaches, think about legislation. What legislation is there to support individuals? So when we go back and we look at burnout or even vicarious trauma, where they're listed as occupational exposures or phenomena. There's legislation around work safety for this occupational phenomena. There may be guidelines and policies in your workplace, but more importantly, as clinicians, as healthcare providers, as pastoral care, health network individuals who've joined this community, one thing we can do is apply learnings into our everyday practice. And that application of knowledge and skills is not only to support those in our care, but also to support us. Because just like on the aeroplane, you've got to put the oxygen on you first before you help anyone else around you. You actually can't be of assistance when you are passed out on the floor on the aeroplane. And this is why it's important that, going back to the Galatians quote, you don't want to be a needless burden to others. And so looking at what supports are available for you to be proactive in care. I've separated change employer, change discipline, leave the profession, because although these are proactive, preventative measures, we need to ask ourselves, am I leaving because it's actually the ethical and right thing for me to do? Or am I leaving because I'm running from something? Am I leaving because I'm avoiding addressing this event, this person, this organization that I find distressing? And if I do find it distressing, why do I find it distressing? What is it about me that I have this expectation or perception that has led to me feeling that I need to leave? There's no right or wrong answer here. I'm just trying to plant some thought-provoking concepts so we can discuss them collectively later. The midstream approach is looking at secondary prevention. So we're trying to minimize harm here. And when we're looking at secondary, what we're trying to do is make it better. So we're looking at enhancing coping skills, but that actually requires insight, capacity, the ability for us to self-reflect and say, hey, what's my role in my own suffering? Rather than taking on board this victim mindset of you did bad to me or you did this to me. What is it that I can do to actually support myself? What is it that I can do to better myself? What is it that I can do to actually help myself and help others in the meantime? So that actually requires some honesty, some truths for us to acknowledge about ourselves. Now, I just want to emphasize that we're not invincible. We're human beings. We have pain at times, and that's actually part of life. So feeling pain, being uncomfortable, this is okay. If we were to feel joy continuously, that would be the extreme. And so this is where we actually need to say, is this event contributing to me growing as an individual? Or is this actually a life-threatening situation that's bringing me harm? Because there's a very big difference between me being on the battlefield at war and me not getting along with my co-worker. Both we may perceive as distressing, but really one's only life-threatening, and that's the soldier on the battlefield. And so what I'm saying here is our perception and our perspective can really dictate how we interpret things. And that when we talk about red flags, it does require some honesty from ourselves. And that can be very difficult and challenging for us. And so we get to the downstream approach, which is actually the event has occurred, we're not sleeping, we're drinking too much, we're eating too much, we're smoking, I'm feeling anxious, I'm feeling overwhelmed, irritable. we need to look at supports now. And we need to look at what can we do to mitigate exacerbation for this individual person. And when I talk about support, I don't just mean support as in um, support for you, but support as in being multifactorial. It might be looking at the employment assistance program that some healthcare providers offer. It might be going to your GP. It might be going to a mental health clinician. It might be going to your priest. It might be going to your spiritual father for confession. And so I've put in support counseling rehabilitation, and QOL is quality of life. And what I want to emphasize here is that life is hard and life can be hard, but we also have a choice in how we view what is happening to us. And so one of my favorite shows when I was a child in the 80s was the A-Team. I loved it. The A-Team, just for in summary, is a bunch of soldiers who were incorrectly incarcerated for 10 years. They broke out and then they became soldiers of fortune, helping people out when no one else could help these individual persons. And what the A-Team was all about was a group of misfits, which you can see from the photograph, where they're completely, all of them are different, but they were actually mutually accountable to the group. And when we talk about teamwork, I just want to acknowledge that bringing it back to feeling burnt out or this compassion fatigue, when we feel valued in the team and that we are of service and contributing something, and we're holding each other mutually accountable, then it appears in the literature that we tend to do better at work, feel like there's a purpose, feel that we are being of service. When I was much younger, I used to coach under 12 soccer team. And I used to say to the kids, hey, like I thought I was being smart. Hey, there's no I in team. It's all about us. And this Bitsidiki comes out and says, but there is I in win and there is I in independence. And it just made me laugh that this 12-year-old was telling me the importance of being an individual, most definitely. But the point I'm trying to make here is that when you feel like you have a purpose, when you feel that you are of value, you are contributing, that can actually help with your health and well-being. And so I bring us to this quote from the Bible where it says, two are better than one because they have a good reward for their labor. For if they fall, one will lift up his companion. But woe to him who is alone when he falls, for there is not a second one to help him. And so this is all about encouragement in the church and how that in itself can bring you comfort. So, Vasiliki, what are some strategies? Help me out here. So, when we're looking at strategies, the sacraments of healing, confession, Holy Communion, Holy Unction, prayer, and fasting. And again, some accountability on our part. This does require insight, but it's something we can practice. When we're looking at effective use of peer support, that could be our colleagues, but it also needs to be someone that you have a trusting relationship with because you want to be able to provide sometimes honest feedback can be a bit harsh, and that's okay, but you want to be able to challenge them without fear of reprisal. And we find that with trustworthy relationships, you can do that. You can say to your sister, your brother, your mother, your husband, your wife, you can challenge them without fear of reprisal. And you can do that with good friends too. What's interesting with supervision and consultation is that sometimes when I was working, I had a colleague who came and said to me, Vasiliki, can you supervise my practice and just give me some feedback on how I'm doing? And I found that by supervising him and providing him constructive direction, improved my own practice. So it might be because it required me to be empathic with what I was saying, but it also required me to not just give him feedback and say, oh, you were terrible or you were great, but give constructive instruction on how he can improve. And that is something we do when we're trying to be supportive. So this is something I just want to, this is a skilling capacity that you may want to consider trying with yourself, your family members, but 3 things to do when we're trying to build capacity. Now, when we're feeling something, we need to actually name it. And the reason why I've highlighted the word joyous is that I don't believe we have a problem saying, I feel happy, I feel excited. Like we're not trying to change that feeling. But when we're angry or sad or annoyed or overwhelmed, there are times that we will actually look to externalize it. And so what this exercise is doing is saying, hey, 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 it's a feeling, man. Relax. Just name it. I feel angry. Okay, I feel angry. Don't say I feel angry because you made me angry. And so just sit with that discomfort because many times we actually have this belief that I can't express. You can be angry without being violent. You can be sad, and that's okay. You can be annoyed, and that's okay too. But what I want to emphasize is this is I put the link in, it's a talk from a Greek Orthodox priest from America, and he says, look, it's okay to feel angry, it's okay to feel sad, but you've got to do something about it. And he talks about these 4 things we can do where we actually have some sense of control over ourselves. We have autonomy. Exercise for 30 minutes, go for a walk, and then do something where you feel you have accomplished something. If you can't build something, fix something. If you can't fix it, clean something. And this is aligned to when you walk into, as a nurse, when I used to do community nursing and you'd walk into someone's house, a messy house was always correlated, it's not a diagnosis, was correlated with someone who was unwell. And so cleaning can actually feel like a sense of accomplishment. And then the priest goes on to say, pray, pray the Jesus prayer, read the Psalms, and more importantly, go and help someone, be of use. Find something that is meaningful for another and go and help that other person. And just by doing these 4 things, people started to improve in their health and well-being. I've put here some resources that may be of use to people. The first resources all the way down to the domestic violence line are for everyone in the group. And then I found a resource for all health clinicians that work for New South Wales Health. There's actually resources available. I put in there from the New South Wales Bar Association because I myself was blown away by how much resources, support, training, education the Law Society of New South Wales had in relation to vicarious trauma for their lawyers. So if anyone in your family is a lawyer, I urge you to bring this to their attention. The Blue Knot Foundation is a resource that New South Wales Health offers to healthcare providers in New South Wales. I've also put down the Medical Association with the link to Vicarious Trauma and, of course, the New South Wales Nurses and Midwives Association. So the top half of this resource is for the non-clinicians, everyone, and then the bottom half is for the healthcare providers. I just want to emphasize that when we speak of suffering, that it's not something terrible. that it is a spark to spiritual growth through humility, and that your mental health isn't something that's fragile that you need to protect. You actually think of it like a muscle. You need to strengthen it in order for us to navigate challenging experiences in our lives. And so the video down the bottom, it's not a Greek Orthodox video. It's actually a video of forgive me, it's of a rabbi talking about the lobster. I don't know if any of you have seen it, but it's the lobster that actually grows. But in order for it to grow, it needs to be under pressure. And so the same is with resiliency. We cannot develop resiliency when our life is easy, when we're on easy street and everything's going great. We develop resiliency through adversity, through hardships, and bringing it back to friction. When there is adversity, that's when actually growth occurs. So when we're looking at avoiding situations that may actually be detrimental. And so again, something I put the only way is through because that's something my spiritual father said to me one day when I was in confession and I was trying to avoid something. And he was like, Vasiliki, the only way is through. You can't put your head in the ground. You just got to walk through it, do it, get it done. And the other thing, as someone who, not as someone, but for those of you in the Zoom meeting, it's important that we listen and we ask questions of the other person to hear what they have to say. Because as healthcare providers, if we're doing all the talking, we're not actually of service because the other person isn't actually divulging information to us. And so I'll finish with St. Augustine, who said that let us understand that God is a physician and that suffering is a medicine for salvation, not a punishment for damnation. So thank you, everyone.